Good day to Inject Nizam. My name is Trey Jain. I would like to present on a case study given today. The assessment that I think are required to plan and implement a dietary intervention are the high vitamin K food checklist and the clinical assessment of signs and syndrome such as nausea, vomiting, erythritidie, taste change, and xerostomia, and also assess the presence of the side effect of the cancer treatment that may impair the food intake and increase the nutrient loss. The biochemical results that I think the most important are albumin, urea, and hemoglobin, and other biochemical assessment that I would advise or to request are prealbumin and platelet counts. The predictive equations that are used to estimate the energy requirements of joints are Harris-Benedict equation, Mifflin-Sergeant equations, and Everton's equation. The protein requirements of joint is estimated using 1.2 to 1.6 gram per kilogram, as joint is on cancer treatment, which is chemoradiotherapy. There are some contributions. Jones undergo a significant weight loss, which is 7.4% within 4 months and 90.9% within 10 months. This may be due to discomfort in the mouth, fatigue, and pain, so Jones has a poor oral intake, and his current intake is less than his energy requirement. This leads to the loss of weight. Besides, Jones also have a cancer cachexia, which alters the nutrition and the metabolic response and result in a syndrome such as anorexia, loss of appetite, erythritidie, and a marked weight loss associated with muscle wasting. The medical intervention for John at this stage of his treatment may undergo a surgery to remove the affected part and radiotherapy or chemotherapy after this. The nutrition and the dietetics diagnosis are inadequate energy intake, altered nutrition-related laboratory values, hemoglobin, and unintended weight loss. The dietetic intervention aims has been divided into short-term and long-term. The short-term aims are to increase the oral intake of John to prevent unnecessary weight loss, to reduce the syndrome of the radiotherapy and chemotherapy, to improve the effectiveness of the medicines preferring to introduce a low vitamin K diet, and to prevent dehydration's occurrence. The long-term aims is to help John to achieve and maintain a weight within a normal BMI, and also to maintain and achieve a normal readings of biochemical parameters such as albumin, potassium, urea, and magnesium. To achieve this aim, there have few steps or intervention that I suggest to educated on John, such as educated on the adequate energy intake. We will ask Johns to take small and frequent meals, such as 3 main meals and 3 snack times a day, which can help to increase the energy intake, and encourage Johns to take ONS, oral nutrition supplement, at a snack time, such as brochure that is for the cancer patient, because brochure is designed for cancer patient to help to gain weight and increase their energy intake. And John is also encouraged to eat food and drink slowly to prevent erythritidie and to increase his energy intake indirectly. Second, to educate on how to resolve the discomfort in mouth due to the cancer treatment. We will encourage John to take a food at room temperature or cold food because they are more tolerated for John, and less other food is suggested to prevent nausea and vomiting, which is also the common side effect of the cancer treatment. We will also educate on the low vitamin K diet due because John is on warfarin treatment. So we will ask John to limit his high vitamin K food to half cups once daily, such as broccoli, spinach, kale, and parsley, and also can take some food that is low in vitamin K in moderation, such as carrot, cucumber, onions, peas, milk, and fish. Adequate or higher iron food because Johns have a low level of hemoglobin indicate he may have anemia. So we encourage Johns to take high iron food such as red meat, tuna, salmon, and beans, and at the same time to avoid some food that may reduce the absorption of iron while eating the high iron food such as milk, dark chocolate, tea, coffee, and orange. And John also have a low serum of potassium and magnesium, so we also educate John on high potassium and high magnesium food, such as take high potassium food, for example, broccoli, spinach, banana, and mushroom, and also the high magnesium food such as nut, legumes, tofu, whole grain food. The last one is to educate on the adequate fluid intake because John have the signs of the dehydration. So we encourage John to sip fluid throughout the days and record the amount of the water intake daily. So that John can know how much water he has drink and how much he have to drink later. So John's fluid requirements that is recommended within 2,300 to 3,000 ml daily according to his current body weight. So what is the importance to document our implementation? I think this is for as a record of the intervention that's given to the patient and as a reference for our next follow-up. So we know what intervention has been given to the patient and we can track it back for better monitoring and evaluations of the patient if they are follow the intervention that's given before. Aspect of John's care that require me to work collaboratively with other healthcare professionals, such as doctor, so that the day-to-day intervention can be modified according to the cancer treatment of patient and suggest the most suitable enteral feeding if needed, according to John's case. And pharmacists to know the list of the medications of John's and to understand the drug-nutrient interaction. One exercise that John can be do regularly, such as a low intensity exercise, because due to age factor of John, which is already 61 years old, so we will suggest him some low intensity exercise such as brief and a slow walk. And John can start exercise once his anemia is resolved and he is not feel very severe fatigue. Okay, if he has anemia or severe fatigue, he have to wait the problems to be resolved or not feel very fatigue, then only can start his exercise. So if discharging John with an enteral feeding, the potential barrier caregiver, we have to educate the caregiver on the enteral feeding, such as the technique of the enteral tube feeding and the preparations of the tube feeding formula. And this is related to the complication and the effectiveness of the enteral feeding at home. The second is the feeding tube management, such as limited knowledge of the tube feeding by the caregiver and the patient itself, John. So inappropriate of the feeding tube management may lead to the complication and hospital readmission, such as the tube dislodging. Okay, and the psychological issue of John, such as the change in the body image, the loss of confidence, and so on. There will be a problems or potential barriers of discharging Johns with home with enteral feeding. The number 13, the outcome measure that I use to monitor the objective that I set previously, such as the weight change. So during the next follow-up, we have to see either John is on weight increments or in weight loss, and other biochemical parameters such as albumin, uric, and hemoglobin. Either these two biochem parameters have achieved and maintained in the normal range or not. And other signs and symptoms that I mentioned before, for example, discomfort in mouth, of John still have any xerostomia, elasticiety, taste change, and so on, that may affect the dietary intake of John. And we also assess the energy intake of John. How frequently that I will recommend John to be reviewed following a completion of his radiotherapy and discharge from ward. I think 1 week after discharge to meet with dietitian to identify whether the feeding regime and the formula is suitable to John. If John is discharged with a home enteral feeding or any complication occur, have to be admitted to the hospital as soon as possible. The impact of the carboplatin may lead to the abnormal blood electrolyte levels such as sodium, potassium, and calcium. And at the same time, radiotherapy also may lower the level of the potassium and magnesium in Johns. And this is related and has been shown in the Johns' latest biochemistry result. Anorexia, or my opinion, anorexia is the most relevant toxicity scoring system. as it will lead to weight loss, dehydration, electrolyte imbalance, which is matched to the John's current situation. Enteral feeding should be initiated if patients consume less than 60% of the energy needs from the food for more than 10 days or unable to eat more than 7 days. The functions of the gastrointestinal tract of the patient must be preserved for enteral feeding. As per guidelines on nutrition in cancer patients, clinical nutrition in 2016 state that in patients with the tumors that impair oral intake of food transport in upper gastrointestinal tract, nutrition status can be stabilized by artificial enteral nutrition. So this is support the nasogastric of the gastrostomy feeding for those patients that do not achieve the energy requirement around less than 60% or they cannot eat more than 7 days but their gastrointestinal still functionable. So enteral feeding, artificial enteral nutrition will be given to them to stabilize their nutritional status. The medical consideration that would be need to be taken into account if John has offered a prophylactic gastrostomy. A careful consideration needs to be given, such as the timing and the method of the gastrostomy placement, with the appropriate screening and the selections for the endoscopic, radiology, and the surgical placement based on the comorbidities and the contraindication. We also have to monitor and evaluate the tolerance of John through the indicator such as vomiting, abdominal distension, cramping, or gangrenous diarrhea and a high gastric residual volume (GRV). This is show the tolerance of John to the current enteral feeding regime and also the enteral feeding formula. Besides, we also have to know the ability of the patient's stomach empty, as a poor stomach empty may result in aspirations, nausea, and vomiting. This will also causing the ineffectiveness of the enteral feeding. Besides, the incidence of irritations at the leakage at the stomach size also have to be one of the medical considerations. I will recommend the prophylactic gastrostomy for Johns as a large retrospective review that shows that weight loss were less with the prophylactic gastrostomy placement compared to the placement as an intervention during the treatment. And every study also showed that gastrostomy feeding seems to be more advantages than nasogastric tube feeding, as patients experience increased mobility, reduced anxiety with out-of-body image, high energy intake, and improve their quality life score with the former. And the gastrostomy groups in our research also use a tubes for longer and have a better weight outcomes compared with the nasogastric group, who experience a greater tube dislodgement and increase the patient's and caregiver dissatisfactions as the study progressed. So there are some effective support within the community or during and after discharge for those with the reactive nasal gastric tubes. For example, do not flush the nasal gastric tube with water of any liquid until the gastric placement is confirmed either by a pH test or X-ray. Do not replicate the guide wire until the gastric placement is confirmed. Never reinsert the guide wire into a tube that remains in a patient. Do not advance the tube against the resistance. Stop insertions if patient shows respiratory distress such as gasping, excessive coughing, or cyanosis and withdraw the tube. Stop if patient becomes distressed. The other supportive rehabilitation programs that I will suggest to reduce the risk of the tube dependency of John are speech and language therapies. This is to optimize the nutrition and the swallowing outcome, dispelling the misinterpreted concept of gastrostomy dependency and optimizing the safe transitions with swallowing from enteral to oral nutrition without compromising the quality of life of Johns in the presence of the side effect from treatments. The long-term side effect of treatment that John may require information about nausea, vomiting, anorexia, weight loss, irritability, constipation, diarrhea, malabsorption, lactose intolerance, xerostomia, taste change, dysphagia, mucositis, esophagitis, orecanitis, and pain. The initiative that may John benefit from once he has been recovered from the cancer therapy and is disease-free is John have to take a healthy balanced diet. For example, he has to avoid high-fat food, high-salt food, and high-sugary food. Besides, John have to consume enough fiber intake by consuming 2 servings of fruits and 3 servings of vegetables daily. John also have to practice an active lifestyle. He have to make sure he's being active at least 150 minutes weekly with a moderate intensity activity. By considerations of his age, hence exercise such as brisk walking is more suggested. John should not take alcohol and smoking as they may be helped in the second cancer. Gastrostomy is more suitable to the patient diagnosed with head and neck cancer than nasogastric feeding, as gastrostomy avoids the mouth and the nose issue. Okay, this table shows the advantages and the disadvantages of the nasogastric feeding and the gastrostomy. The advantages of nasogastric is cheap, can be used in short term, do not need any anesthesia used in the insertions of the tube, but disadvantages of nasogastric is it cannot be used in the long terms of tube feeding and it must pass through our mouth and nose. In gastrostomy, its advantages such as can be used in long term, avoid interfere with the gastroesophageal sphincter, avoid the mouth and the nose, and normally it is better tolerated by our patient. But gastrostomy is more expensive, and if short term we cannot use a gastrostomy and is more invasive and require endoscopy before the insertions of tube. The risk factor that is associated with decisions of making gastrostomy placement is first is the functions ability of the gastrointestinal tract. Because gastrostomy requires a functionable gastrointestinal tract for digestion and absorption. The period of time of the enteral feeding will also one of the factors that affect our decision making. Normally a long-term enteral feeding, then only we will choose a gastrostomy instead of nasogastric tube feeding, which is more suitable for short term. And the discharge plan of patient will also affect the decision making because sometimes changing tube in home is available for gastrostomy and the feeding through the gastrostomy also will be faster compared to nasogastric tube, and this will be ease the work and the burden of the caregiver. The guideline that I use for refeeding syndrome is according to the MNT guidelines, nutrition support in critical use adults. The refeeding syndrome is defined as a severe electrolyte and a fluid shift associated with the metabolic abnormalities patients undergoing refeeding, whether orally, enterally, or parenterally. The clinical features are fluid balance, abnormalities, abnormal glucose metabolism, hypophosphatemia, hypomagnesemia, hypokalemia, and thiamine deficiency. This syndrome occurs due to the rapid shift of the electrolytes, including potassium, phosphorus, and magnesium, from our extracellular to our intracellular space, along with the sodium and the water retention, as well as the rapid flux in the insulin production with the response to the carbohydrates route. Patients at risk of refeeding syndromes are those with costocosis or malaise, chronic malnutrition, prolonged fasting, anorexia nervosa, chronic alcoholism, post-operative patients, and cancer patients. So for this case, if John is being initiated with an enteral feeding, he's at high risk of being refeeding syndrome. So his feeding regime must be monitored and evaluated from time to time. To assess a patient is either have a refilling syndrome or just a deranged electrolytes as a result of the chemotherapy. Based on my humble opinion, I will assess the serum phosphate of the patient. Normally, patients with a refilling syndrome have a hypophosphatemia. This is because the food deprivations change in the way of our body to metabolize the nutrients. In the absence of the carbohydrates, the body retains the stored fats and the proteins as a source of the energy. Over time, it can be deplete the electrolyte store, especially phosphate. Because phosphate is needed to convert the glucose into the energy, it is often affected. When the food is reintroduced, there is a shift from the fat metabolism back to the carbohydrate metabolism. This causes the insulin secretion to be increased, and the cell needs like phosphate to convert the glucose to energy. But now our phosphate is in a short supply, so this will lead to another condition called hypophosphatemia. So normally patients with refeeding syndrome, mostly they have a hypophosphatemia, which is low in phosphate. But a patient with a deranged electrolyte, it may also have a hypophosphatemia, but it's not very much in the deranged electrolytes. So these are the reference that I used in the case study to answer the 28 question today. So thank you. That's all from me today.